Yeah, it's recording in cloud, not a problem.
Yes, sir. Yes, sir.
Yeah.
Shall I start, sir?
Yeah, please.
A very good morning to all of you. I am Dr. Kaustubh S. Thackeray, and today we are going to discuss about solving the puzzle of maxillary sinus lift in a simplified way. Every family has an angel who is providing everything to that family, who is taking care of his or her family. So my father was an angel for our family. So I would like to pay a homage to my late father, Dr. Suresh B. Thackeray, before starting with today's discussion. Just imagine you have a teacher who is very strict, who is very knowledgeable, who has taught you many things, not only in your professional life, but also in your personal life. Then it becomes very difficult for you to present something in front of him. So right now I'm facing a similar situation, but I know, like always, Chaudhary sir will be supporting me this time also. So with this, we will be starting with our today's discussion. All of you watch movies, right? We Indians are big movie fans. So whenever we watch movie, the most important part of any of the movie is screenplay of that movie. Now screenplay, there are of two types, like linear screenplay and non-linear screenplay. If you used to watch the older movies like Swerve, there was linear screenplay. That means story was starting from A, then it was moving to B, then sequentially it was going till the Z. But nowadays, the movies like Attack, the screenplay is non-linear. We are starting from somewhere M, then we are coming back to B, then we go to X, and then to A and Z. So when there is non-linear pattern of the screenplay, we feel thrilled. And with linear pattern, sequentially the story is moving on. But as our topic is simplified one, I will be following the linear pattern. Sometimes you might feel that I am talking two basic things. So please bear with me. And with this, we are starting with today's discussion. So we all know that placement of implant in maxillary area is frequently compromised. Mostly when you are talking about posterior maxilla, this treatment plan is more compromised. And this is because of atrophy of the alveolar bone. So whenever a tooth is extracted, there is resorption of the bone. This resorption of the bone is even faster in cases of maxillary posterior area. So it creates a problem for implant placement. The quality of the bone here is D3 or D4. So when we say D3 or D4, that means more amount of the cancellous bone is present and very less amount of the compact bone is there. Because of that, the softness of the bone is more, which creates a problem for achieving primary stability of the implant. Apart from that, whenever the tooth is extracted in maxillary posterior area, sinus starts expanding and it leads to pneumatization of the sinus. So these all factors make it difficult for us to place implants in maxillary posterior area. So when we talk about treatment of choice, this treatment of choice is dependent upon several factors. The first and the most important factor is vertical height of residual alveolar bone. We also call it as residual bone height. Another factor is local intrasinus anatomy. Whenever we are placing implants, we are going for any kind of the procedure in maxillary posterior area, we should be well aware with the sinus anatomy. When I talk about sinus anatomy, I mean to say that we need to understand where exactly the sinus floor is placed. Is there presence of any septa? If the septa are present in the sinus, what is the number, whether single or multiple? How is the lining of the mucosa? These all things we have to take care of. And lastly, the number of the teeth to be replaced. Are you going for a single tooth replacement or multiple teeth replacement? That also is going to dictate your treatment plan. So considering this, in posterior maxilla, which has got limited residual bone height, several treatment options are there. The first one is short implant. Then we have angled implant, zygomatic implant, and sinus lift procedure. As we have decided to talk about the sinus lift procedure, I will not be talking more about the other treatment modalities. Every treatment modality here, which is mentioned, has got its pros and cons. We are going to focus on sinus lift procedure. So when we say about sinus lift procedure, first we should know what do you mean by the sinus and where exactly the sinus is located. We all are well aware that in orofacial region, several paranasal air sinuses are there, which are ethmoid sinus, frontal sinus, and maxillary sinus, which is also called as maxillary antrum. This maxillary sinus or maxillary antrum is the largest of all the paranasal air sinuses, and the dimensions are around 24 millimeter by 33 millimeter by 23 millimeter. It is located in the body of the maxilla. It is pyramidal in shape, and there are three main processes. The first one being alveolar, which is towards the alveolar bone. It is the inferior process. Another one, which is the superior process, which is towards the orbit, is infraorbital process. And the laterally, towards the zygomatic bone, we have zygomatic process. In the sinus cavity, we get a bilaminar membrane, which is Schneiderian membrane. So let us now come to the sinus floor elevation. Previously, the term which we were using routinely was sinus lift procedure. Now it has been called as sinus floor elevation. This technique is basically intended to increase the vertical bony dimensions in the posterior maxilla so that we can appropriately place the implants in a proper position. So most important thing whenever you are going for any kind of procedure, maybe a surgical procedure or non-surgical procedure, is patient selection. There are several prerequisites which we should fulfill before starting with the procedure. And these prerequisites are a sound understanding of anatomy of maxillary sinus, because there are very many variations in the anatomy of the maxillary sinus which we intend to know. And once we are well aware with that, it will be easier for us to start with the sinus elevation procedure. Second, and the most important part whenever we are going for any kind of surgical therapy, is a thorough medical history. As it is rightly said, if you don't know indications, then it is okay, but you should always know the contraindications of each and every procedure. If you know that your therapy is going to be successful, it is also important to reject few patients rather than doing a procedure in each and every patient. If any condition is there that compromises the bone healing, like radiotherapy, or a patient with diabetes with poor glycemic control, then you should be well aware with patient's condition. Certain medications like anti-disruptive drugs. Now these anti-disruptive drugs are bisphosphonate drugs, which usually a patient is taking who has got osteoporosis. It can be given in through the oral administration or systemic administration. So you should be well aware that what is the mode of dosage, how it is administered. Apart from that, if patient is on any anticoagulant therapy, if the patient is on anticoagulant therapy, according to newer recommendations, where that patient is taking a single dose or patient is taking double dose, that also you should be well aware of. And the most important factor is smoking. We are all aware that smoking plays a significant role in delaying the healing and causing the failure of many of the therapies, specifically implant related therapies. So regarding that also we should be well aware of. With this, let us now come to the indications of maxillary sinus elevation procedure. So first one being insufficient bone height for conventional implant placement. Now here there might be some debate regarding the bone height for conventional implant placement. I will like to share one incident with you. When I was doing my scholarship, at that time I used to read Kalmish. So according to Kalmish, he has mentioned that minimum 9 millimeter of the implant length should be available and it should be placed, because after that a proper bone to implant contact you are going to get, surface area is more. So I asked the same question when a presenter who was my mentor's friend was presenting regarding the short and ultra short implants, that how it is possible to get a successful therapy by placing implants of 4 millimeter or 6 millimeter. So he was very furious with me. He said that we don't know what niche is telling. We are following the ITI philosophy, where even 4 millimeter implants in height can be considered as conventional implant. So it depends again on the clinician's skill and clinician's experience, that what height they are considering suitable for placement of conventional implant. So now what we will take, a 9 to 10 millimeter is the sufficient height which is required for placement of conventional implant. So if it is not there, we have to think about the sinus elevation procedure. Next, there should be no local or systemic condition present. which can compromise the bone healing or the immune response, as already we have talked about. Now, these are the things which we should definitely know, that is absolute contraindication. So the first absolute contraindication is high dose head and neck radiotherapy, including maxilla. We all are aware that whenever a patient is undergoing radiotherapy, there are chances of osteoradionecrosis. So the bone quality is poor, bone quality is not good. So in those conditions, we should not attempt for any kind of sinus elevation procedure or implant procedure. If patient is on high dose anti-disruptive therapy, if a patient is taking systemic doses of anti-disruptive therapy, that too for a longer period of time, then they are absolutely contraindicated for the sinus elevation procedure. Third is active chemotherapy. If patient is on active chemotherapy, then we should not go for any of the procedure. After chemotherapy, taking a proper physician's consent, we can proceed for the further treatment. If your patient has got poor cooperation, patient has got history of substance abuse or any kind of emotional disorder, these patients are not able to maintain the implant, the oral hygiene, so they are not the candidate for placement of the implant and for sinus elevation procedure. There are several relative contraindications where we have to take utmost care and then proceed with the procedure. This includes a diabetic patient with poor glycemic control, but you have to make your patient aware that if you are not maintaining your sugar levels properly, then your treatment is not going to be successful. Secondly, long-term anti-disruptive therapy, more than 5 years, but patient is on oral bisphosphonate. Systemic bisphosphonate or systemic anti-disruptive therapy is absolutely contraindicated. But if your patient is on oral anti-disruptive treatment, then with some precautions and care, we can proceed with the treatment. In smokers also, we know the blood supply is reduced, but taking proper care, we can proceed. But you should always be aware of the failures in such cases, and you have to make your patient also aware regarding the same. Several risk factors which we have to keep in mind, and why we are talking about these risk factors, because we have to let our patient also know that these are the risk factors, and if they are present, then patient is also responsible, similar to that of the clinician. So these risk factors are high risk factors. First one is chronic and acute periodontitis. Now, when we talk about periodontitis, it again has got two forms: active periodontitis and inactive periodontitis. Acute periodontitis is always active periodontitis, but chronic, it might be active or it might be inactive. So if it is active case of the periodontitis, it is a very significant risk factor. But if patient is inactive periodontal patient, then we can proceed with the treatment. So simple question is that how to understand whether it is an active periodontitis or inactive periodontitis. So you have to just check the gingival status. If there is bleeding on probing, if there is suppuration, if color is bright red, if soft and edematous consistency is present, it all indicates that it is active periodontitis. And in inactive periodontitis, these things will not be there. So in inactive periodontitis patient, you can proceed with your treatment. Second is acute sinusitis. Those patients who have got sinusitis, there are chances of aggravation of the disease if you are going for sinus elevation procedure. If the tooth adjacent to the maxillary sinus has got any kind of the infection, then also it is a high risk factor for the success of our treatment. There are several moderate risk factors which include smoking, abnormalities in the sinus membrane which are caused by infection, and minimal residual bone height. If we are talking about sinus elevation procedure, usually the sinus elevation procedure is intended to be done when residual bone height is less. But that doesn't mean that with every kind of residual bone height, our treatment is going to be successful. You have to be very careful because residual bone height itself is a risk factor for the success of the therapy. Once you are taking the informed consent from your patient, you should always discuss all these factors with your patient before starting with the procedure. One of the better ways to assess the sinus anatomy, the area which you will be operating, is radiographic technique. So in that, we have two combine the two-dimensional radiograph with the three-dimensional radiograph like CT scan and cone beam computed tomography. It has been mentioned that you should always go for preoperative CT scan or cone beam computed tomography before you are starting with your surgery to evaluate maxillary sinus anatomy. Why PGCT is important? Regarding that, I will be talking when we will be discussing about the complications. So what is intended is to have a proper cone beam computed tomography before starting with your sinus surgery. As we all know, nowadays cone beam computed tomography is commonly utilized for implant therapy because of low radiation dose. International Team for Implantology, they have given some recommendations for the radiographic technique, like at what visit which radiography is mandatory. So for initial visit, you just require a periapical radiograph and panoramic radiograph. Before surgery, PBCT is mandatory. After surgery, like you elevated the sinus, you just want to check, then you can have periapical radiograph. After placement of the implant, again a periapical radiograph is fine. For long-term monitoring of that area where you are operated, there also a periapical radiograph is fine. But if there is any emergency and you want to check the sinus area, then you have to go for a CT scan or cone beam computed tomography scan. Let us come to the treatment planning now. The treatment plan, like any other implant placement, is decided by prosthetically driven plan. The number of the implant, what dimensions we will be placing, what will be the position of the implant, it all has to be planned according to the prosthetically driven criteria. And as I have said, the most important factor which is dictating the treatment plan is bone height, residual bone height. It is going to tell us that which technique you should utilize when going for sinus elevation procedure. Let us now come to the sinus floor elevation surgical technique. Mostly we always talk about two techniques, that is lateral approach and osteotome approach. Different names have been given in literature for these procedures. Like lateral approach, it is also called as lateral window technique or direct sinus lift. Osteotome technique, it is also called as indirect sinus lift or transalveolar technique or transcrestal technique. So next time, if you get to hear these terms, try to understand that these are the different names given to the same procedure. First, we are going to talk about the lateral window technique. This lateral window technique was described by Bowen and James in 1980 and further by Tatum in the year 1986. It consists of elevation of the flap, getting access to the lateral part of the alveolar bone, creating a window in the lateral sinus wall, elevation of sinus membrane, then placement of the graft material for augmentation, and finally placement of the implant. This technique is indicated if the residual bone height is 6 mm or less than 6 mm. Now this is the criteria which we have to keep in mind, that if residual bone height is 6 or less than 6, we have to opt for lateral window technique. If it is more, then we have to go for osteotome technique. So first part is flap design. We are directly talking about the clinical procedure which we will be following in lateral window technique. So the first and important part is flap design. In relation to implants, we must have heard about two incisions, that is crestal incision and remote incision. It is already known to you that whenever we are going for any kind of augmentation procedure, we have to use remote incision, which will be placed 1 to 2 mm away from the crest on the palatal side. So here also we are giving remote incision. This remote incision is 1 to 2 mm away from the crest, and it is 4 to 6 mm away from the inferior border of the estimated window which we will be preparing. We are going to talk about that. Once you have given the remote incision, the next part is giving buccal vertical releasing incision. These are given for proper displacement of the flap and to have accessibility to the lateral part of the alveolar bone. Next part is blunt dissection. Whenever you are using a periosteal elevator for reflection of the flap, that is called as blunt dissection. So it is going to lead to reflection of mucoperiosteal flap, that is full thickness flap, it has to be reflected 4 to 6 millimeter apically beyond the upper portion of the bony window outline. Here, partial thickness slab will create a problem because periosteum will be remaining onto the bone. There will be more bleeding and it will be very difficult to prepare a window. So whenever you want to work on the bone, we have to reflect buccoperiosteal flap. So this is how, after giving remote incision, flap is reflected and the lateral part of the bone is visualized. The next part is outline of the bony window. Now we want to make a bony window onto the bone which we have exposed after reflection of the flap. That's why we are calling it as lateral window technique. So the size of the window, it will be decided according to the area which has to be grafted. The osteotomy, it might be oval or rectangular in shape. Many of the clinicians, they prepare oval osteotomy. Some of them, they are opting for rectangular osteotomy. Inferior outline is 3 to 5 millimeter above the sinus floor. So now imagine from crest your sinus floor is 3 millimeter away. So the inferior outline has to be prepared 6 to 8 millimeter away from the crest, because as we have told that it has to be 3 to 5 millimeter above the sinus floor. So from crest to sinus is 3 millimeter, then the inferior outline will be 6 to 8 millimeter apical to the crest of the bone. Size of the upper window, it will be decided according to the length of the implant, which you have decided pre-operatively only. Mesial border, you can take that as far as distal to the canine if you are placing multiple implants, or if you want to replace many teeth. And distal border, that also you can take till the tuberosity. But basically the mesiodistal dimensions of the window, they are depending upon the mesiodistal diameter of the implant and the area which you are trying to graft. Next part is preparation of bony window. So you have to use a number 4, 6 or 8 diamond burr, and as you know, like in all implant procedure, we have to use copious saline irrigation. Once the outline is prepared, the next part is thinning the bone. It has to be thinned using the smooth light sweeping motion until the translucent area is visible and the underlying gray or red color of the sinus membrane can be seen. So this is how we are preparing either an oval osteotomy or rectangular osteotomy. Once the osteotomy outline is prepared, the next part is thinning of the bone using the burr so that grayish red area of the membrane is visible to us. I will show you clinical picture also. Here outline is prepared. You have to take care that you should not go too deep, otherwise there are chances of tearing of membrane. And then, as I have told you, you have to thin the bony window, the bone which is present around the outline, that we have to thin. When we are doing this, what is happening is that we are getting a bony island in between. In between the outline, we are getting a bony island. How to take care of that bony island? We can either infracture the bony island by carefully elevating the sinus membrane. So this island is going to lie on the top of the graft material and it will be going to form the roof of the sinus. Or in another technique, we can also remove it, which is wall-off technique, with the help of the sinus lift elevator. There are advantages and disadvantages of each of these procedures. If you are infracturing the island and using it as a roof, then it will be acting as a ceiling for graft material and implant. But the disadvantage is that there will be impinging of this bony island onto the medial antral wall and there are chances of perforation. If you are using wall-off technique, then a coagulum is going to get formed around the apical part of the implant, which is further providing the progenitor cells for formation of new bone. And also the visibility is improved. That bony island can be crushed and can also be used as autogenous bone particles and bone chips. But again, a major disadvantage here is there are chances of sinus membrane tearing. The next part after this is elevation of sinus membrane. For elevation of sinus membrane, we have different elevators available in the market, which we have to use for elevating the sinus membrane. So the first part is we have to gently detach the membrane at the apical aspect of sinus cavity. Once this is done, then we have to move to the medial side and distal side, and afterwards we have to go to the upper border. After releasing all the borders properly, next is going medially, and medially we have to elevate the membrane. So this is how the membrane will be elevated. Here you can see that bony island is still forming the roof. So this is in-fracture technique, which was described by Tatum. These are the different sinus elevators which are available in the market. So according to the area of use, different sinus elevators are there. Next is using the bone graft and barrier membrane around the cavity which we have prepared, the lateral window which we have prepared. So basically, different clinicians are talking about different type of graft materials and which is suitable for them. Like if you go nearer to the USA, they are more fond of allogenic bone graft, and European people, they are more commonly using xenograft. If you ask me that what is better, so I am going to follow my mentor. My mentor has told that xenograft has got slower resorption rate. We want to maintain the space of the sinus cavity till the new and de novo bone formation is occurring. So it is always better to use a graft which has got slower resorption rate to maintain that space. We can mix autogenous bone graft with xenograft. We can have a mixture of autogenous, xenogenic, and alloplastic bone graft. Even we can also add allogenic bone graft. The problem with allograft is that if you are using it here, there will be higher resorption, and because of that, the space will not be maintained for appropriate period of the time. If you want to enhance the quality of the bone, we can go for osteopromotion by utilizing different type of growth factors. A commercially available growth factor, which we all must be aware of, is GEM21S, where we get platelet-derived growth factor along with beta-tricalcium phosphate, or I think some platelet-derived growth factor gel is also available in Chennai. The difference is that that gel is available for 10,000, while a GEM21S, it is costing around 50,000. So again, it depends that what we are using. We are doing a study on that gel from Chennai. So if we are getting good results, I will be sharing that also with you. So our cost ratio will be reduced because of that. Whenever we are placing graft, what we do, we want to have tight compaction, but that is not advocated. Because when you are tightly compacting the graft, no space will be there for de novo bone formation. We want more space for the primitive bone to get formed. So for that, tight compaction of the graft should be avoided. Another thing which we need to understand whether to go for simultaneous implant placement or delayed implant placement. So it all depends upon what type of primary stability you are going to achieve after placement of the implant. So if in the residual bone height you are getting adequate primary stability, then we can go for simultaneous implant placement. So while going for simultaneous implant placement, you have to first prepare the implant bed, like what we prepare during routine osteotomy. But here the implant tip is going to get exposed into the created component in maxillary sinus. That tip of the implant is then covered with the bone graft material, and then the lateral window has to be covered by resorbable collagen membrane. Now again, which type of the membrane we are using, it all depends on clinician's personal experiences. If the stability is compromised, then you have to wait for at least a period of 4 months to 12 months after the augmentation. In any of the cases, whether you are going for simultaneous implant placement or you are delaying your implant placement, you have to wait for a period of 3 to 6 months after implant placement before going for prosthetic loading. So this is the procedure, a pictorial format of the procedure. First, outline of the window, then infracturing the bony island, placement of the implant. You can see the tip of the implant is exposed into the sinus cavity in the picture C. In the picture D, bone graft is placed and then membrane is placed onto that. So this is a case which I have done under the supervision of my mentor when I was doing my ITF scholarship. We had opted for simultaneous implant placement. Straumann implants are placed here. Boney Island was infected and was used as a root. Implants were placed. After placement of the implant, that cavity was then filled with the xenograft, that is BioOS, and then it was covered with BioGuide, that is collagen membrane. Let us now come to the staged approach. Like means first you have done the lateral window technique, and because of inadequate primary stability, you have waited. So after reflection of the flap, you can see something like this. When you use xenograft at that time, the picture will be something like this. You will still appreciate the bony particles, the bone graft particles, because of the slow resorption rate. Implants were placed in a staged approach. Here you can appreciate the xenograft more properly. This was the implant placement after 6 months of augmentation. After waiting a period for 4 more months after placement of the implant, gingival formers were placed. Abutments were then connected, and the final prosthesis is given. So this whole technique or the whole procedure has taken around 12 months. But if you want to have a successful procedure, then you have to wait for such period of the time. Because what is more important is long-term success than saving the time of the patient and saving your own time. So when we talk about some of the research, sir has already told me that don't talk much about research, but I am just telling you the facts associated with the research, that regardless of the used graft material, the survival rate was equivalent. Whether you are using autogenous bone graft, xenogenic bone graft, or combination, the implant survival rate was equivalent. Meta-analysis, which we consider as the peak form of the pyramid of the research, it has stated that if you are using autogenous bone graft, mixture, or bone substitutes alone, whether you are placing a delayed implant or you are going for simultaneous implant placement, this procedure of lateral window technique is highly predictable and it is going to give long-term implant treatment outcome. Let us now come to the complication. We, as an implantologist, we basically are doing surgeries also. So we are basically surgeons. So we have to be well aware regarding the complications which can occur while doing any of the procedure. So the most common complication is perforation of sinus membrane. If you meet some people, they are very scared about the perforation of sinus membrane, but it is the most common thing which is going to occur because it is a very delicate thing. Membrane is very delicate. There are chances of perforation when you are performing any kind of sinus elevation procedure. That perforation, it can be repaired by using a collagen sponge or by a collagen membrane or by suturing the tiered membrane. But if there are extensive perforations, then it is better to abort the procedure and wait for a period of time and then again redo the procedure. When we talk about management of the perforation, there are several recommendations which have been laid down by international team for implantology. It depends upon how much is the perforation. So if perforation is 5 mm or less, just suture the torn membrane and proceed with your procedure. If it is 5 to 10 mm, then you have to use collagen membrane or oxidized cellulose membrane, something like this. And if it is more than 10 mm, then abort the procedure and you can use a block graft or a buccal pad to cover that area. The next is intraoperative bleeding. Usually, when you are going for sinus elevation procedure, the intraoperative bleeding is less and it is manageable. But you have to be very careful about something which is called as intraosseous alveolar antral artery. It can be seen in 44% of the cases. It is basically an anastomosis between the posterior superior alveolar artery and infraorbital artery. It is not visible on routine OPG and IOPS. When I was talking about CBCT at that time, I had told you why CBCT is important. Here you can see that is the arrow where it is present. It is intraosseous alveolar antral artery. If you are taking a CBCT, then you can prevent any violation of that artery and there will be less bleeding. But if by chance you are violating that artery, there are chances of heavy bleeding in the sinus cavity. So first way of prevention is by using physiosurgery and cone beam computed tomography. Physiosurgery for every case it is not possible. So one recommendation which again ITA has given that limit the height of osteotomy to 18 millimeter, because there are chances that after 18 millimeter this intraosseous alveolar antral artery might be present. So always next time when you will be going for any kind of sinus elevation procedure, specifically lateral window technique, you have to limit your osteotomy till 18 millimeter. Next is displacement of the implant in the sinus. This is also a complication which you have to take care of. Now this is my own case. Myriad implants were placed in this case. So again, depending upon the bone quality, you have to decide which implants will be placing. I placed Myriad implant here. We all know that Myriad or Equinox implant, they have got a greater thread pitch. Very less threads are there on the implant surface, and surface treatment is also not that adequate. It doesn't mean that implants are not good. Those implants are also good, but with every case you have to select proper implant. Sometimes patient is not paying, so you should not go for any implant. You have to check for the bone quality and then you have to decide which implant system is suitable for the particular bone quality. So I was sharing my case. During the second stage surgery, when I was trying to place gingival former, I could place one gingival former, but the second implant was not visible. So I took one periapical radiograph using RBG, but implant was not visible again. So I asked the patient to go for OPG. Next day when patient came back, the implant was there into the sinus cavity. So what we had to do is to reflect the flap, expose the lateral part of the alveolar bone, similar to that of Cardwell loop procedure, prepare a bony window, and then the implant was taken out. Bone graft and PRF membrane was placed and sutures were placed. So this can happen. So that's why meticulous treatment planning is very important. Sometimes when you do lot of procedures, you think that every procedure you can follow the same protocol. Like if you are using 20, 25, 30 implants a month, for every patient you think that same protocol is going to get successful. But no, for every patient, you have to give a personalized treatment protocol. Like if I would have followed this protocol, then this complication might not have occurred. But complications can occur. If you are doing more work, there are always chances of more complications which you have to manage. Other complications which can occur are post-operative infection. There are chances of around 2 to 6% of post-operative infection after sinus elevation procedure. But we have to consider that every patient is somewhere between those 2 to 6%. So adequate medications and adequate precautions you have to take to prevent the post-operative infection. There is always a chance of sinusitis after going for sinus elevation procedure. Exposure of the graft and membrane can also occur. There are chances of hematoma. As you know, hematoma is more common in the maxillary posterior area, so you should be aware of that also. Vertigo can also occur. Regarding vertigo, I will be talking when we are discussing about osteotome technique. So finally, what conclusions and clinical recommendations have been given in literature regarding the lateral window technique? First, it is a safe and predictable procedure and morbidity is low. It has to be used when the residual alveolar bone height is less than 6 millimeters. There is also one technique which can be done, that is lateral window technique without graft and simultaneous implant placement. As we have seen in Wolof technique, if you are using a Wolof technique, there are chances of coagulum formation, and that coagulum formation releases growth factors which will lead to de novo bone formation. A new bone regeneration is going to take place. So some of the authors, they have advocated this technique. It requires sufficient vertical height to achieve primary stability, because in this case, simultaneous implant placement we have to do by any cost. Delayed implant placement is not advocated because implant preserves and supports the elevated membrane. In this case, to simultaneous implant placement we have to go for. So this is the technique. The technique is similar to what we have seen with the graft, similar technique we are following. Only thing is that bone graft is not placed. The red color which you see in B and C around the implant, that is formation of the coagulum. Now this coagulum will be taking the progenitor cells from the sinus and leading to new bone formation, but the cavity we have to cover with the membrane. So for this procedure, there are several conclusions and clinical recommendations. It is again a safe and predictable procedure. Complications are less and has got high short-term implant survival rate. This is why it is written as short-term implant survival rate, because longer studies have not been done. No consensus is yet reached regarding this technique. It is solely recommended for placement of single implant. The next technique is now osteotome technique. We have talked about the first technique, that is direct sinus lift. Now we will be talking about the another technique, which is indirect sinus lift. It is also called as osteotome technique, transcrestal technique, or transalveolar approach. So Tatum had published an article in 1986 where a specialized instrument was used, which was called as socket former. So that socket former was placed inside the osteotomy site, and then the sinus membrane was elevated. Here, no bone graft was used by Tatum, but Summer in the year 1994 modified this technique by using a specialized instrument called as osteotome. These osteotomes were used progressively with increasing diameter and placement of bone graft to achieve the lateral and apical condensation of the bone graft as well as elevation of the membrane. So the principal aim of this treatment is again to conserve and increase the amount of the available bone for implant placement. The bone is compacted laterally and apically around the implant with the help of osteotomes of progressively increasing diameter. Here, the implants are inserted immediately to support the elevated floor of the maxillary sinus with the cnidarian membrane. It is suitable for the placement of single implant, but nowadays we are using it for multiple implants also. It is less invasive and less time consuming. And when we say it is less invasive and less time consuming, we might think that first we should learn about the indirect sinus lift. But if you ask any teacher, if you go and ask Chaudhary sir, or for matter any of the mentors who are imparting the implant education, they will always tell you first you have to master the lateral window technique, and once you have mastered the lateral window technique, it is very easy for you to manage osteotome technique. So basically, we all have to practice a lot regarding the lateral window technique, and then we should start doing the osteotome technique. Clinical procedure for this is, first you have to prepare the osteotomy with a 2 mm cylindrical burr, similar to what we prepare for normal implant, but here the depth is 1 mm below the sinus floor. So if sinus floor is till 8 mm, you have to prepare the osteotomy till 7 mm only. Then that osteotomy is enlarged to 3 mm in diameter. After that, the graft material is added, and then 3 mm osteotomy is used with advanced malleting force to infracture the apical bone and for elevation of the sinus membrane. So this is how we are preparing the osteotomy first. This osteotomy is 1 mm shorter to the floor of the sinus. Then bone graft is placed, and with the help of the osteotome and light malleting force, membrane is elevated and bone graft is compacted. The clinical procedure, further we are talking about that. Once the tip of the osteotome has reached its desired height, then we have to just widen the osteotomy depending upon the diameter which you have chosen for your implant placement. But we always have to take care that the final osteotome diameter should be narrower than the desired implant width. It is usually 0.5 to 1.2 mm less to get proper primary stability. This undersizing of the osteotomy is very helpful for achieving the osteocompression when we are working in D3 and D4 quality of the bone. Specifically in maxillary posterior area, we are talking where we are getting D3 and D4 bone quality. The final step is to check the resistance by inserting the final osteotome or a guide pin, and also to check whether any perforation has occurred or not. Usually, we can safely place a 2 to 3 millimeter of the bone graft material around the apical portion of the implant. This is also helpful in adding to the primary stability which we have achieved. There are several advantages and disadvantages of these techniques. So the advantages, it is less invasive as compared to that of lateral window technique. In single step, we can do sinus lift implant placement similar to that of normal implant placement. It is of shorter duration. Compared with lateral window technique, it is cheaper because not much of the bone graft is required, not much of the costly specialized instruments are required, and there is less risk of bleeding. The disadvantages are, it is a blind procedure. You have elevated the sinus, but you don't know whether the sinus perforation has occurred or not. There are high chances of membrane perforation, and as compared to that of lateral window technique, it is less predictable in the terms of gain in new bone. Osteotome technique again can be done with grafting or without grafting. Let us see some clinical pictures of the case which has been done with grafting. So elevation of the flap, similar to how you prepare the osteotomy site for routine implant placement, we are preparing that. But you have to keep in mind that it is 1 millimeter below the sinus floor. Then the osteotomes of progressively increasing diameter are used to widen the osteotomy site and also to elevate the sinus membrane. These osteotomes are usually concave in shape, so that it will not add much pressure to the membrane while elevation. Next step is placement of the bone graft, and again compacting that bone graft with the osteotome, and finally placement of the implant. So this was the case which I had done recently. You can see the sinus membrane is around 6 to 7 millimeter from the crest, and if you can appreciate the bone graft around the implant, so that bone graft is nicely having a tent shape. This is also an indication whether you have perforated the membrane or not. If you have perforated the membrane, your bone graft will appear as scattered. But if your membrane is not perforated, a nice shape of the bone graft will be visible to you onto the radiograph surrounding the apical portion of the implant. So what bone graft usually we should use? Again, it depends on clinician, but a combination or a composite bone graft is recommended. Like utilization of the autologous bone graft along with different types of bone substitutes like allograft, xenograft, or alloplast we can use. If you want to have faster formation of new bone, more autogenous bone graft can be added, which was advocated by our author. But other author has told that even if you are adding increased amount of the autogenous bone, there is no guarantee that it will lead to increased amount of the newly formed bone. So it again depends. Without grafting, again, the procedure which we are following is the same like what we have followed with grafting. This is the case. So 8 millimeter space is there, and we want to place a 10 millimeter of the implant. This is preoperative view. Flap is reflected. Routinely, how you prepare your osteotomy site. 1 millimeter apical to sinus, you have to prepare it. Osteotomes are used without any bone graft material, and then implant is placed. And you can see nicely, you can appreciate that the membrane has got elevated. After 6 months, placement of the abutment, and then final prosthesis was given. So if you want to talk about the success of osteotome technique, it is similar to what we get in non-augmented bone, like with the conventional implant. It is proportional to the residual alveolar bone height. If residual alveolar bone height is more, you have selected an appropriate implant, then you are going to get good success. The success is also proportional to implant length. So this question I have kept for debate. Like we have many implantologists who have joined this Zoom link. We will be talking about that what according to them is the implant length minimum we should have. Clinical outcome is higher than 90% of success we will be getting with this technique. No statistically difference was found when this technique was utilized with graft or without graft material. If residual bone height is more than 5 millimeter, then higher survival rate we have achieved. And shorter implants which are less than or equal to 6 millimeter, if you are using with osteotome mediated sinus flow elevation, then there is significantly decreased implant survival rate. So you cannot combine these two techniques. Maybe this was a study which was done long back in 2000. Maybe now we can say that, okay, indirect sinus lift can be done and even a short implant can be placed, but body support to that implant is less, so there are higher chances of implant failure in these cases. The complications which can occur are perforation of membrane. The perforation of membrane can occur because of oblique maxillary sinus floor, presence of sinus septa, root apices penetrating into the maxillary sinus. When we talk about sinus septa, a classification has recently been given in 2013 that this septa case can be classified as easy, medium, and difficult, depending upon the size of the septa, the number of the septae, orientation of the septae, and accordingly also we have to plan our treatment plan. So you should always look for whether the sinus septae is present or not when you are evaluating the case pre-operatively. There is chance of post-operative infection, nose bleeding. If you think that nose bleeding can occur, ask your patient not to blow the nose for at least 5 days so that the nose bleeding will not get increased. There are also chances of blocked nose, formation of hematoma, chances of benign paroxysmal vertigo, and post-operative bleeding. See, whenever you are using two metals together, there are always chances of vertigo to the patient. We are not going in detail why this vertigo occurs, because there is something which is present near the auricle which gets displaced and it keeps on flowing freely, and because of that there are chances of benign paroxysmal vertigo. I will just tell you how to prevent this. For preventing this, when you are using a mallet onto the osteotome, keep a piece of cotton or a piece of gauze onto your osteotome and then use mallet with a light malleting force. So it is one of the techniques which has been recommended to prevent vertigo post-operatively in the patients with osteotome-mediated sinus elevation procedure. It is a very predictable and reliable approach, but if you are using shorter implants, you have to be careful because there are decreased chances of survival of the implant. It is indicated if the residual alveolar bone height is 6 millimeter or more than that. You can use autogenous bone graft, bone substitutes. You can also use growth factors if you want to gain more intrasinus bone. So decision tree was given by Fugasato in the year 2000. Though this decision tree was given in the year 2000, like 22 years back, still for treatment planning, it is relevant now also. So if vertical height of the residual alveolar bone is 5 millimeter or more, we can safely go for osteotome mediated sinus floor augmentation. If it is 5 or less than 5, then you have to go for lateral window technique. In that also, first we should check regarding the implant stability, whether primary stability is achieved or not. If not, then delay the implant installation for a period of 4 to 12 months. If yes, then we can go for simultaneous implant installation. But in any of the cases, after placement of the implant, we should wait for a period of 3 to 6 months for proper osseointegration. According to the newer guidelines, 2 months of the period is also enough. But I think in posterior maxilla, 2 months of period is not enough. Many of the time, when we open the flap for second cervical side and check the implant, still some kind of osseointegration is not achieved. So it is better to wait for a period of more than 3 months. That is my personal experience. If the buccopalatal width of the ridge is less, so in this case, it is always better not to opt for osteotome mediated technique. You have to opt for lateral window technique. So if it is less, residual bone height is also less than 5 millimeter, your width is also less, then you have to go for a staged approach. First, lateral window technique, wait for a period of 6 to 8 months, then placement of implant, then again wait for a period of 3 to 6 months, and then delivering the prosthesis or prosthetic loading. If it is more than or equal to 5 millimeter, then depending upon the primary stability, we have to check whether to go for simultaneous implant placement or delayed implant placement. In any of the cases, we should wait for 6 to 8 months. If you are placing implant simultaneously, wait for a period of 6 to 8 months, not 3 to 6 months before restoration. And if you are going for a staged approach after the implant procedure, wait for a period of 3 to 6 months. Many of the techniques have been described. There are many modifications for osteotome technique. You must have heard about Koski's technique, where they are not using the osteotome. Rather than that, a specific drills have been formulated to be used for indirect sinus lift. Then we have osteodensification with the use of Densa burrs, Versa burrs. But I'm not going to talk about all those things because osteodensification is a totally different topic. A different lecture will be required for it. A different presentation will be required. So I'm just talking about two techniques, that is sinus ballooning technique and hydraulic pressure technique or hydrostatic pressure technique, which you must have heard about, that too in very brief. So sinus balloon technique, which is also called as minimally invasive antral balloon augmentation. It was designed by Zimmer. Zimmer has given different cannula for different surgical procedures, like angle design, straight design, or micro mini design. So if you are going for osteotome mediated technique, they have advised to use the straight cannula. For lateral ballooning, for lateral window technique, the angled cannula, and if the diameter of the osteotomy site is less, around 2 millimeter, 1.9 millimeter, then micro mini design. So the clinical procedure is somewhat similar to what we are following in osteotome technique. First, preparation of the initial osteotomy, 1 to 2 millimeters short of the sinus floor. Then a small diameter osteotome is used for penetrating the sinus floor. After that, you have to insert the sinus balloon inside. The care should be taken that before inserting it inside, first you have to inflate and deflate it externally several times to check whether it is working properly or not. After that, once we insert the balloon inside the sinus cavity, we inflate it, we get a sinus lift of around 6 millimeter with this procedure. So around 6 millimeter bone also you can place, but so much of the bone if we are placing, we will not be getting adequate length for placement of the implant. Next part is placement of the bone graft and then placement of dental implant. So these are the pictures which I have taken from the book. I have used this technique. When you use ostium or a dentition implant, they provide you this. I used it, but photographs were not proper. So I'm showing you the photograph from the book. So here first the osteotomy is prepared. On the left side you can see that is preparation of the osteotomy, and on the right side we can see the sinus balloon which is inserted inside the osteotomy site which you have prepared. Then placement of the bone graft and then placement of the implant. One more technique is there, which is hydraulic sinus lift. So in hydraulic sinus lift, we want to achieve equal distribution of the hydrostatic pressure so as to prevent formation of any kind of point pressure and perforation of the sinus. So for that purpose, there is a calibrated hand controlled pump and pressure sensometer. So we know what amount of the pressure we will be applying onto the membrane with that pressure sensometer, and with the hand control pump, we are elevating the membrane. So again, this is a pictorial presentation of the technique. First, we are preparing the osteotomy similar to what we are preparing in the osteotome technique. Then we are using the hand pump for elevating the membrane, and you can also check what pressure has been applied. So if pressure is controlled or not, then the placement of the bone graft if you want, and then placement of the implant. The treatment planning plays an utmost important role whenever you are going for any kind of sinus elevation. I will just share a case with you where somehow I misinterpreted the radiographic findings and thought of going for implant in that case. So if you can see this picture, this has recently happened to me like 1 month back. 5 implants were placed, and again during the second stage surgery, implant was not visible. Implant was not visible in periapical radiograph. OPG was taken, and you can see it appears that the implant is present in orbit. So it is a scary situation for patient also, and sometimes for we also, we think that where the implant has gone and how the implant has gone into the orbit. This was because I opted for a short implant with indirect sinus lift. At that time, the primary stability, it was okay, 25 to 30 torque I had achieved. But then at that time only, I should have stopped the treatment, delayed the treatment, should have gone for lateral window technique and then placement of the implant. As it is, now I had to go for the lateral window technique for removal. Now this is not into the orbit, this is near to the roof of the sinus, like infraorbital process, but it appears in OPG that it is in the orbit. So this is how you have to take a proper call when you are going for implant treatment. Basal implant people, they will give you an option of going for basal implant. So it has also got its advantages and disadvantages. It depends, but like I am placing more of conventional implants. So first I have to learn properly about basal implants so that I can place basal implants also in such cases. So I hope I have not created a scenario something like this with all of you, and something interesting has been there in my lecture. I want to thank my teacher and the organizer, Dr. Chaudhary sir, for giving me this opportunity. I also want to thank Dr. Mudula, who was constantly in touch with me regarding this presentation. And finally, I want to thank all the audiences for their patient learning. So if you have any question, please feel free to ask me. If I know the answer, I will tell. If I don't know, then I will find the answer and will try to tell it to you. Thank you.
Thank you so much, Kaustubh. Can you make me the host, please?
Yes, sir, shall I stop sharing? No?
Yeah, you can stop sharing and you can make me the host. It was a very nice and basic to advanced presentation. I think it was like an overview, and I feel it was very apt for my fellow students for BOCI, because they just come and intervene and start asking me that they want to do sinus lifts. So I think this was a good eye opener for them, that what all procedures or what all measures to be considered before you take up a sinus lift case. Kaustubh, we have some questions before. 1 second. Hello.
Yes, sir. Yes, sir.
Yeah. There are some questions. I'll go from one lecture. 1 second. I'll go from Dr. Deepak. Deepak is here.
Yes, sir.
Yeah, can you ask them your questions? I think.
Yes, sir. Sir, good morning, sir.
Good morning, Dr. Deepak, sir.
Sir, following radiation, how long we should wait for the sinus lift procedures, sir?
Sir, according to the literature, we have to wait at least for a period of 6 months after going for radiation therapy. But what usually we do is we take consent from the operating surgeon who has done this, and then only we go for it. Now, not many articles are there after radiation therapy.
Yes, sir.
But in between, we had decided to do an animal study on the patient on the radiation therapy, and then to check the results. So right now, I will say that we have to wait for the consent, and then only we have to go for the procedure. So sir is showing us some of the literature.
No.
Sir.
I'm just
yes.
yeah.
Hello.
Yes,
Yeah.
sir. Yes, sir.
any
Deepak.
other- How do we repair perforated lining in indirect sinus lift? Again, Deepak has asked this question.
Sir, in indirect sinus lift, it is very difficult to manage with the perforated membrane lining because the area where we are working is a very small area where we have prepared osteotomy site. So we don't know whether the perforation has occurred or not first. We are performing the Valsalva maneuver to check the patency of the sinus, and if we think that there is no patency, then sir, it means in that small area we cannot even place anything. We cannot suture the perforated membrane. With direct sinus lift procedure, we can well manage the perforation. So that's why it is always said that first we have to master with the lateral sinus lift, and then we have to think about the indirect sinus lift.
But the
So
people,
can
but
also
many
add to-
many people try it the other way because this looks very easy.
even I was trying it the other way only initially. Afterwards, I started doing the lateral window technique.
Okay.
Sir,
Yeah.
hello.
Yeah,
Yes,
Deepak.
sir.
Sir, after you see the IOPA, if there is dispersed granules of the graft
Yes, sir. Yes, sir.
particles into the sinus, so it is advisable to go by lateral technique and cover it with membrane, or if it would be a small tear, you can wait and watch, sir.
So if there is a small tear, you can wait and watch. And sir, even
Yes,
if
sir.
you are not doing anything and just aborting the procedure, afterwards you can just uh, deviate the angle slightly, and then also you can go for your implant placement.
This is with indirect sinus lift, sir.
Indirect sinus lift, sir. Indirect only I'm telling. Yes, sir.
Okay, sir. Okay, yes.
Okay. So there's one question. Direct sinus lift without grafting, how do we decide?
Sir, it depends upon the clinician's experience. As I have told you, uh, basically what we students do, we follow our teachers. So my teacher, he was using autogenous bone grafts and xenografts more, and he has also given the reason for it to me. Like xenograft has got slow resorption rate. We want to maintain that space for a longer period of time till the new bone formation starts. Usually, in any of the area, whenever we are going for any kind of procedure, minimum 6 months are required for formation of new bone. So the graft which we are using should maintain the space for at least 6 months, and it is difficult with allogenic bone graft. So it is recommended to use a combination of autogenous bone graft and xenogenic bone graft. You can also use a combination of alloplastic and xenogenic and autogenic. But using only allogenic or only alloplastic is not recommended because of their properties. Like it is better to go for xenograft and autogenous bone graft or combination of different types of the graft.
Yeah. Then there's a question. Next question. Can we say that balloon technique is safer than other techniques?
If you master that balloon technique, for us that it can be safer technique, but I had placed for 2-3 implants with balloon technique, but I
Okay.
got failure in the balloon technique. Then I had to go for lateral sinus lift with the same case. So from that point
Yeah.
of time, I am not using it routinely. So I'm not the right person to comment on this, whether it is the
I
safest
think
procedure or
Deepak
not.
has used in 1 or 2 cases, isn't it, Deepak? Hello.
Hello, sir.
Deepak, I think you have used balloon technique, right? I think I have.
Balloon dentium I have used, sir, only indirect sinus lift.
So how do you
Yeah.
feel about it?
For indirect sinus lift, it is good, sir. It works, sir.
Okay. Okay.
Since sharp instruments don't come in contact with lining, the chances of perforations are less, sir.
Yes, sir.
Exactly, sir. And I also think that the amount of inflation that we do, that is also controlled, and the how much ever we want the elevation that could be achieved with it. That is why I asked this question.
Yes, Mishika.
Okay. Yes.
Yeah. So there's one more question. Anyway, how are you, Mishika?
Sir, very well. Just packing,
Okay.
ready to go in 10 days.
Oh, good. There's a question from Dr. Khulud. Indirect sinus lift, if perforated of membrane, happens, do we still can place graft?
That graft will get displaced into the sinus cavity. So the purpose for which we are placing the graft, that will not be solved if the membrane is perforated. Implant stability you can get in that case also. Even if your implant is staying into the sinus and it is stable, then it is not going to create a problem unless and until any infection occurs around it. So implant placement you can do, but like that bone which has been lost, which has the membrane which has been perforated, new bone formation around that will be difficult in these cases.
Okay, I have 3 more questions before I leave you.
Yes, sir.
Why did you say that autogenous graft is not very apt for sinus lift?
No, autogenous, no. Allogenic bone graft is not very apt, I told.
Yeah.
Autogenous
I was wondering that. I think she has taken it another way. Autogenous is always good.
always good because of
Yeah.
osteogenesis, osteoinduction. Most means the preferable bone graft is autogenous only, but like for autogenous bone graft, we require second surgical site.
Yeah.
Everyone will not be possible to procure autogenous bone graft.
Yes. Yeah. Then one more question is: can you please explain about the platelet-derived growth factor? You said you will give us more input on this.
Yeah, platelet-derived growth factor. I had done my thesis on JM21S. It was not used in relation with the implant, but it was for regeneration of the infrabony defect, and I got very good results. You must have heard about tissue engineering approach. So the tissue engineering approach states that if you want to get regeneration, now what is regeneration? It's complete formation of new tissue which was lost. We need to have 3 things at place. That is stem cells, the signaling molecules, and your bone graft or scaffold. So stem cells we are getting from the bone itself. Growth factors we are getting from the bone, the blood clot, which we need to preserve, but it is not in that amount which we require. So we can always use a commercially available platelet-derived growth factor for achieving this triad and to get a proper regeneration. So any time if you are opting for the growth factors, they are going to lead to osteopromotion. In relation to the bone graft, we talk about several properties like osteogenesis, osteoinduction, osteoconduction. Most of the graft materials which we are using, they are osteoconductive. They are just preserving the space. We need to have osteogenic bone graft, which is only autogenous, and only one type of allogenic bone graft is osteoinductive, that is BFDBA. There is one more property which is osteopromotion. That osteopromotion property, if it is achieved, then that bone graft itself might lead to formation of new bone along with osteogenetic property. So to achieve that property, we need to have growth factor.
Okay, that is very informative for me as well. There's last question, I think. How tightly we need to pack the graft in a indirect sinus lift sinus lift?
Indirect sinus lift. Yeah, indirect. Yes, sir. So, like the pressure, I'm not able to tell it exactly, but with light malleting force only, you have to do not much of the force you have to apply.
I think Pranav Raj, I think I can answer that. If you have seeing a bleeding, that means it is too tight. You are perforated. So you have to not pack it. You have to keep it as a volume, but not pack it very tightly, I feel.
Yes, sir.
Isn't it? Yeah, off the record, just I happened to see one of my best friend in the participants, Dr. Sachin Manglekar.
Yes.
See, now he's smiling, now he's coming out.
As soon as you said one of my best friend, I switched on the video and unmuted myself.
How are you?
Fine, Ramesh. How are you?
Thank you. Yes. So Kaustubh knows you, right?
Yeah.
Yeah.
He was the one who sent me the link.
Yeah. I got it. Thank you for attending, dear.
Yeah, it was really informative, and I told all my students also to attend it. They are attending.
Thank you so much. I thank all the participants and especially Kaustubh, because it's always proud moment for me. If any of my students present, I think Sachin can understand that. Because
Definitely.
Kaustubh has done great things in research and all that. So a token of appreciation from our side, Kaustubh, you will be getting a hard copy of certification, but this is for you. Please accept.
Yes, sir. Thanks a lot, sir. Thanks a lot for
Yes,
giving me
and
this time.
you have to just text us your home address so that we send you the hard copy. Thank you
Yes,
again.
sir.
Thank you all of you, and thank you, Sachin. And
Yeah,
we will invite you for a lecture on lasers now. I just got a click on my mind.
Sure, sure. We'll do that
Yeah,
for
yeah.
sure.
Thank you
Yeah.
so much. Thank you so much.
Okay.
Thank you,
Thanks
sir.
a lot.
Thank
Thanks a
you.
lot, sir.
Thank you all of you guys.
Yes. Thank you, sir.